Welcome to this educational video on chest pain. It is one of the most common and high-stakes complaints in medicine. Today, we will reason like clinicians at the bedside, following one patient's story to build a comprehensive framework covering the differential, pathophysiology, workup, and management of this critical condition. Let's meet our patient. He is a 58-year-old man who arrives with an hour of substernal chest pressure. He describes it as feeling like an elephant on his chest, radiating to his left arm. It began during exertion, and he appears anxious and diaphoretic. His vital signs on arrival are also noted here. By the end of this video, you will be able to build a 5-system differential for chest pain, explain the pathophysiology behind visceral and referred pain, and distinguish between type 1 and type 2 myocardial infarctions. We will also cover how to interpret diagnostics and apply the heart pathway for risk stratification. The patient's story is key to his diagnosis. His pain is exertional, constant, and dull rather than sharp. It radiates to his left arm and is associated with diaphoresis. Critically, the pain is not pleuritic, positional, or reproducible by chest wall pressure, which helps us focus on potential ischemic causes. Regarding his history, he has hypertension and hyperlipidemia, though he is poorly adherent to his medications. He is a 30-pack-year smoker with a family history of premature myocardial infarction. These are important, as each of these factors significantly raises his pre-test probability of having coronary artery disease. Our physical exam remains targeted. While his blood pressure is elevated, it is equal in both arms, which makes aortic dissection less likely. His lungs are clear, and he lacks chest wall tenderness. These findings help us narrow our differential, continuing to prioritize ischemia based on his clinical presentation. It is important to remember that chest pain is a symptom, not a diagnosis. It is a doorway to many potential conditions spanning 5 organ systems. Our primary task is to triage danger and diagnose the underlying cause, treating the patient as having ischemia until proven otherwise. The significance of this complaint is clear. While only 5 to 10% of emergency department visits for chest pain result in an acute coronary syndrome diagnosis, the stakes are incredibly high. A missed myocardial infarction is a critical safety issue and a common source of medical malpractice claims. Moving into part 1, let us discuss pathophysiology. Understanding the mechanisms of how the body experiences pain is essential for interpreting the clinical signs we see at the bedside. We will focus on why the chest hurts and how this pain is sometimes mislocalized. Pain is generally categorized as somatic or visceral. Somatic pain is sharp and localized, while visceral pain, like cardiac pain, is dull, diffuse, and poorly mapped. Patients often struggle to point directly to the source of cardiac pain, as it typically presents with autonomic symptoms like nausea and sweating. This diagram explains why cardiac pain refers to the jaw and arm. Visceral afferents from the heart and somatic afferents from the chest wall converge on the same neurons in the spinal cord. Because the brain cannot distinguish the origin, it misinterprets the signal as coming from the body wall. The pattern of radiation provides valuable clinical clues. Radiation to the right or both arms is more strongly associated with ischemia than left arm radiation alone. Epigastric pain can also indicate an inferior wall MI. Always remember that while radiation can refine your assessment, its absence does not rule out ACS. Ischemia is fundamentally a balance of supply and demand. In a type 1 MI, a plaque ruptures, causing a thrombus that obstructs blood flow. Alternatively, a supply-demand mismatch can occur even without a plaque rupture, triggered by factors like tachycardia or anemia, eventually leading to myocardial injury and elevated troponin. To maintain this balance, we consider the determinants of supply and demand. Supply is influenced by coronary flow and diastolic filling time, while demand is driven by heart rate, contractility, and wall stress. Tachycardia often worsens ischemia by increasing demand and limiting the filling time available to the heart. Finally, the universal definition distinguishes between type 1 and type 2 MIs. Type 1 is caused by plaque rupture and requires antithrombotics and reperfusion. Type 2 arises from a supply-demand mismatch and is managed by treating the underlying stressor. Both involve troponin changes, so the clinical context is vital. Moving into the second part of this video, we build our differential. Discipline is key here. Even when the heart is the leading suspect, you must systematically evaluate other systems so you do not miss a second killer. This wheel outlines the 5 families of chest pain. We have cardiovascular, pulmonary, gastrointestinal, musculoskeletal, and miscellaneous causes. Keep this framework in mind as we walk through each family and identify the conditions that can be lethal. We begin with the cardiovascular family, where 4 of the 5 main conditions can be lethal. Learning the specific patterns for acute coronary syndrome, pericarditis, aortic dissection, and pulmonary embolism is crucial for guiding your evaluation. Here is an overview of the cardiovascular 5. Notice that while acute coronary syndrome accounts for less than 10% of emergency chest pain presentations, it dominates our workup because of its high mortality risk and the urgency of its management. Acute coronary syndrome symptoms often include substernal pressure made worse by exertion. While features like diaphoresis increase the likelihood of ACS, sharp or positional pain makes it less likely. Remember that clinical features nudge probability, but none rule the condition in or out on their own. The electrocardiogram is central to evaluating ACS. We look for ST elevation or depression, T wave changes, or Q waves, always comparing them to prior and serial tracings. If pain persists despite a normal initial ECG, repeat the tracing because patterns can evolve over time. Pericarditis often presents with sharp pain that radiates to the trapezius ridge. It typically improves by sitting up and leaning forward. The ECG shows diffuse ST elevation with PR depression. When troponin levels rise, it is classified as myopericarditis, requiring careful monitoring for potential tamponade. Aortic dissection is a critical diagnosis to exclude before initiating any anticoagulant therapy. Look for sudden, tearing pain, pulse or blood pressure differentials, or a widened mediastinum on a chest X-ray. It is a surgical emergency that requires immediate diagnostic imaging. Pulmonary embolism typically presents with sudden, pleuritic pain, dyspnea, and tachycardia. While the classic S1Q3T3 pattern on an ECG is famous, it is not highly sensitive. Biomarkers like troponin and BNP can indicate right heart strain, which signals a larger, higher-risk clot. Pulmonary hypertension causes exertional pressure due to right ventricular ischemia. Physical exam findings may include a loud second heart sound and a right ventricular heave. It is a progressive condition, and exertional syncope is a red flag that necessitates urgent referral to a specialist. When we compare these cardiovascular conditions side by side, specific patterns emerge. A tearing sensation pointing to the back suggests dissection, while pleuritic pain suggests PE or pericarditis. Each condition has a high-yield bedside test that guides our next diagnostic steps. We now move to the 4th part of our video, the pulmonary family. These conditions are often pleuritic, meaning the pain worsens with breathing. Keeping these in your differential is vital, especially when dealing with sudden onset respiratory distress. Pulmonary causes often share a pleuritic quality. Pneumonia is characterized by fever and cough, while a pneumothorax presents with sudden dyspnea and decreased breath sounds. Attention pneumothorax is a medical emergency requiring immediate decompression before imaging. Pneumonia is confirmed by fever, productive cough, and focal infiltrates on a chest X-ray. Because lower lobe infections can sometimes mimic abdominal pain, it is important to be thorough. We use standardized scoring to assess severity and guide antibiotic treatment. Finally, pleuritis is an inflammatory condition that causes sharp, localized, and breathing-related pain. Because it is a descriptive diagnosis, you must always look for an underlying cause like an infection or pulmonary embolism before finalizing your treatment plan. Next, let's explore pulmonary causes of chest pain, starting with pneumothorax. It presents with sudden, sharp, pleuritic pain and acute dyspnea. Exam findings include decreased breath sounds and hyperresonance on the affected side. Remember that tension pneumothorax is a clinical diagnosis. You must decompress it immediately. Moving to the gastrointestinal family, we find the great mimics of cardiac pain. Conditions like reflux and esophageal spasm can be indistinguishable from angina. While we need to be thorough, remember that these are diagnoses of exclusion. Always clear the heart first. There are 6 key gastrointestinal causes to consider. From GERD and esophageal spasm to Mallory-Weiss tears and Boerhaave syndrome, these range from benign to life-threatening. Peptic ulcer disease and pancreatitis round out the list, often presenting with abdominal symptoms that can radiate to the chest. GERD presents with substernal burning and an acid taste, worse after meals. While a trial of a proton pump inhibitor can be diagnostic, be very careful. Relief from a GI cocktail does not rule out ischemia, and this false sense of security can lead to missing a heart attack. Esophageal spasm is a notorious angina mimic. Because it can improve with nitrates, this response is not specific to cardiac disease. Manometry is the diagnostic gold standard, but your priority must always be to exclude myocardial ischemia before finalizing this diagnosis. Mallory-Weiss and Boerhaave syndrome represent a spectrum of esophageal injury. While a Mallory-Weiss tear is usually self-limited, Boerhaave syndrome is a full-thickness rupture and a surgical emergency. Look for severe pain and evidence of mediastinal air in these patients. Peptic ulcer and biliary disease often present with epigastric or right upper quadrant pain. Crucially, an inferior myocardial infarction can mimic these symptoms perfectly. Always order an electrocardiogram for any patient presenting with upper abdominal pain to rule out cardiac disease. Acute pancreatitis classically causes boring epigastric pain that radiates to the back and improves by sitting forward. Diagnosis requires an elevated lipase and lipase to amylase ratio. While primarily an abdominal condition, it frequently refers pain to the lower chest. Finally, we consider musculoskeletal and miscellaneous causes. These are common and often benign, but they should only be labeled as such after the life-threatening conditions have been systematically excluded. This group includes costochondritis, muscle strains, herpes zoster, and anxiety. While costochondritis is reproducible with palpation, remember that tenderness does not provide a free pass. You must still consider the possibility of coexisting heart disease. Costochondritis causes sharp, localized pain that worsens with movement. The hallmark finding is tenderness when palpating the rib cartilage. While it is a common diagnosis, always document the negative cardiac workup to ensure you have not overlooked more serious pathology. Herpes zoster, or shingles, causes intense burning pain in a single dermatome. In the window before the rash appears, it can be a diagnostic challenge and mimic many other conditions. Once the vesicles emerge, the diagnosis is confirmed. Anxiety and panic disorder are diagnoses of exclusion. They often present with tightness, palpitations, and breathlessness. However, never dismiss a patient as simply anxious until you have confirmed a normal ECG and troponin. Now that we have reviewed the differential, let's discuss the workup. The systematic approach remains the same for every patient. A focused history and exam, an early electrocardiogram, troponin testing, and imaging targeted to the specific conditions you suspect. Remember that typical presentation is just the start. Many patients, especially those with diabetes or older adults, may present with atypical symptoms. When you are uncertain, lower your threshold for testing. Don't let an atypical story lead you to miss a serious diagnosis.